at the University of Toronto. Thank you so much for joining me to open this year's conference. I'm really excited and really thrilled to be here. Although we're meeting virtually today, I would like to acknowledge the Indigenous peoples of all the lands our speakers inhabit. I do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. I encourage you to reflect on the land on which you're located and to consider your relationship to the land and to the people who are the traditional keepers of that land. Here at the AgeWell Network office, or not here in my home, but at the AgeWell Network office in Toronto, we operate on the traditional territories of many Indigenous nations, which have cared for the land for thousands of years, including the Anishinaabe, the Chippewa, and the Haudenosaunee and the Wendat peoples. And we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis peoples, and is subject to the Dish with One Spoon Wampum, which is an agreement to peaceably share and care for the Great Lakes region. I am grateful to have the opportunity to work on this land and to acknowledge our accountability and responsibility to further the reconciliation process. And AgeWell is committed to fostering equitable and inclusive practices across all of its programs and explicitly welcomes and strives to incorporate Indigenous ways of knowing and being throughout our research and education programs. Our programs also seek to address inequitable access to higher education and funding by supporting especially underrepresented groups. Okay, so AgeWell is Canada's technology and aging network. AgeWell is dedicated to the creation of technologies and services that benefit older adults and caregivers. And our aim is really to help older Canadians maintain their independence, health, and quality of life through technologies and services that increase their safety and security, support their independent living, and enhance their social participation. Launched in 2015 through the federally funded Networks Centers of Excellence, NCE program, AgeWell addresses a wide range of complex issues in technology and aging through receptor-driven transdisciplinary research, training programs, partnerships, knowledge mobilization, and the commercial development of technologies. In other words, AgeWell was launched to address a very real need. The need for better solutions to address the challenges of aging well in Canada. Older adults, as we know, are a rapidly growing segment of the Canadian population. There are now more people over the age of 65 than children under the age of 15. And in fact, population estimates indicate that 1 out of every 4 individuals will be 65 years or older by the year 2030. The Canadian population is aging faster than ever before. This is a massive demographic shift, and our health and our social services, businesses and products must change to accommodate both the existing and emerging needs of an older population and those who care for them. As a network, AgeWell brings together researchers, students, government, industry, and most important, older adults and caregivers to create and implement technologies and technology-based services and policies to increase well-being and quality of life. Since 2015, we have grown to support over 350 researchers, trained over 1,300 trainees and research staff, engaged with more than 425 industry, government, and nonprofit partners who have joined our network, and the numbers continue to grow. Over 5,000 engaged older adults and caregivers are involved in these partnerships to ensure that products are practical and useful, among many other important contributions and insights. Our researchers have created over 170 solutions, including technologies, services, and policies. We support over 60 startups, many of whom have grown from network-supported research, and many of which were founded and run by network trainees. As a network, we believe in making real-world positive impact, and we believe that this is best achieved by pursuing collaborative impact. Only by working together across disciplines, sectors, regions, provinces, and yes, by working closely with our stakeholders and co-creating with them, can we truly generate better health outcomes and make real the Age Well vision. That is to have Canada's leadership in technology and aging benefit the world. So here we are at the EPIC conference. This EPIC conference is now in its 4th year. And it was also born out of a need, a pandemic-driven need to create a new virtual and accessible space in which our trainees and stakeholders could share their stories and learn about the innovative work being done across Canada and network with colleagues around the globe. We are proud to report that the Age Well EPIC conference is the largest virtual conference in the age tech space, convening 1,000 delegates each year from over 18 countries across 6 continents. The EPIC conference's continued success is testament to the persistent need we see to continue to build and scale the age tech sector in Canada and worldwide. So in this 4th year, our EPIC conference program remains rich, and we invite you to join us over the next 9 days from May 23rd to June 2nd for 8 panels of research presentations by trainees and stakeholders that emphasize how we are moving the dial in this sector. These research presentations are organized across the 8 Age Well challenge areas, that is 8 complex problem areas that we have identified as spaces that demand age tech innovation and the deployment of real-world solutions now. You'll also have a chance to hear from our stakeholders, especially those who are older adults and caregivers with lived experience. They're integral to these sessions, and I, for one, am absolutely looking forward to hearing their critical insights. This year, we're also offering a hands-on workshop hosted that's entitled Addressing Barriers and Facilitators to Technology Implementation. And by participating in this workshop live, you will receive a certificate of completion from the Center for Implementation. So I will encourage all of you to check out the Age Well EPIC conference website to download the EPIC conference program and to register for each one of our sessions if you haven't done that already. All EPIC conference sessions are free of charge, and everyone is welcome to attend. So I encourage you to join the conversation, ask the questions, even the tough questions, challenge assumptions, and learn about the innovations that could make a difference in your life or the life of someone that you hold dear. So as we come together to collaborate, connect, and foster an inclusive community over the next 2 weeks of this virtual conference, we recognize a shared responsibility to create and hold that environment for the benefit of all. So with that, we value the participation of each member of the community, and we endeavor to deliver an enjoyable and fulfilling experience. EPIC conference participants are expected to conduct themselves with integrity, courtesy, and respect for others, and maintain the highest level of professionalism at all event sessions. All attendee speakers, organizers, partners, sponsors, and staff are required to observe our code of conduct, which you may read on the EPIC conference website. So very importantly, I would very much like to thank the organizers of this event, our Age Well partners, stakeholders, especially older adults and caregivers, and members of Age Well's Older Adult and Caregiver Advisory Committee, who are critical partners in our success. And of course, we'd like to thank the Age Well students, postdoctoral fellows, research staff, early career researchers, and EPIC AT fellows who are here to share their important research with all of us. So the future of age tech most certainly has never been brighter. Okay, so now that I have officially opened the EPIC conference, I'm going to change my hats, and I'm going to introduce our first session. And our first session is on the topic of supportive homes and communities, and I am the session chair. And as such, I will open my session chair notes. Okay, so we're really excited to have 3 EPIC presentations as a part of today's session on supportive homes and communities. The 3 presentations will be by speakers Laura Ault, Amal Yayadin, and Shiroz Khan and Penny Taylor. Before we begin, I'd like to note a couple things. First, just a reminder that challenge area presentations will take place on Zoom from 1 to 2:30 Eastern Time today to Thursday this week and every day next week. And on Friday, May 26th, as I mentioned already, join us for the EPIC, or maybe I didn't mention this, join us for the EPIC conference workshop, addressing barriers and facilitators to technology implementation, which will be presented by Executive Director of the Center for Implementation, Julia Moore. And those who attend the full session live will receive a certificate of completion. Again, please check out the AgeWell EPIC conference website for any additional details. So just a couple of housekeeping things for today's session. So today's session will be comprised, as I mentioned, of 3 oral presentations, a 5-minute Q&A session following each presenter, and then an overall discussion with a general Q&A that places the presentations in a larger discourse and addresses the potential research impact. So all attendees are encouraged to use the Q&A box to ask questions or to leave a comment about a question, and also to upvote questions that others have submitted. So this session is being recorded and it will be available for playback, and the links to the playback will be posted on the EPIC conference webpage and on the AgeWell YouTube channel. Okay, so now for the fun part where we get to listen to some fantastic presentations. The first presentation is going to be by Laura Ault. Laura has been working as a research coordinator for the Bruyere Research Institute located in Ottawa for just over 5 years. With her background in engineering, her projects involve sensing technology to support aging adults and allow them to continue living in their own homes. When she's not working, she enjoys taking the dog for a nice long walk, especially now that summer is here. And she wants to thank Bruyere AgeWell and TalkTech for their continuous support on the research project. So I'm going to invite Laura to share your screen to give your 10-minute presentation. I will let you know once that 10 minutes is over, and we very much look forward to hearing what you have to tell us about today. So on to you, Laura.
Excellent. Thank you so much, Jennifer. Can somebody just give me a thumbs up that we see my screen and my presentation?
Yep, we can see it.
Excellent, excellent. So thank you everybody for joining today, especially after such a beautiful long weekend. It finally feels like summer's here, at least if you're in Ontario. Today my presentation is called Learnings Around Bringing Technology into a Care Home Setting. So as it was mentioned in my introduction, I have been doing research with the Bruyere Research Institute for about 5 years now. And a lot of my research projects have been around bringing technology into care settings, whether that's into people's homes to allow them to age in place, or into actual formal institutions to support both sort of residents and care staff. Today, I'm going to give you guys a little bit of an overview about project partners, our project overview, explaining a little bit on the technology and the research site, but then the big sort of chunk of the presentation today is actually going to be around the learnings of bringing technology into a care space. And then I'll close off with some user thoughts as we collected those from the end of the study, and finish off with a little bit of conclusion. So our partners for this project were very wide. Of course, the Bruyere Research Institute and TalkTech Technologies, as TalkTech was the technology we were bringing in. And then, of course, we used our connections with AgeWell, Carleton University, Taffeta, and OBio, which is the Ontario Bioscience Innovation Organization. I do just want to give a shout out to Dr. Frank Knofel, Dr. Bruce Wallace, and Dr. Neil Thomas for their continued support during the project. And of course, a big thank you to Jessica Yang, the CEO of TalkTech Technologies, and all of her team over at TalkTech for their incredible support throughout the project. So I'll give you a bit of a background on the project, like the actual project overview. Again, I do want this presentation to focus a little bit more on the learnings, but to make sure everybody's on the same page, our goal or question for this project was, can bed sensing technology support the workload and efficiency in night staff workers in a care home environment? And so with that, we installed a bed occupancy plus sensor, and I'll get into a little bit more of that in the next slide, but the sensor does a little bit more than just bed occupancy. So we installed this bed occupancy sensor in 14 beds at a location local to me, of course. The sensor was in the study for 3 to 4 months, I'll say. And the idea was that this sensor could send alerts to the night staff through cell phone. And these would be either when a bed exit occurred or a set time delay after. So for those who are high falls risks, we can send an immediate alert to the cell phone to the night nurse saying, room 123 is out of bed. Or if there's less of a concern for falls and the residents allowed to get up, go to the washroom on their own and return back to bed safely, then we could have a time delay. So let's say 15 minutes. And after those 15 minutes, if the resident hasn't returned back to bed, the staff could be just made aware that there was a bed exit, and maybe their assistance is then required, and they can sort of make that call themselves. So that's sort of the general overview of the project. The technology. So that sort of black square in the middle of the screen there, that is the sensor. So it's actually a bed sensor that goes underneath the leg of the beds. It's very similar to sort of a puck or coaster, and it comes with a placebo puck so that your bed's not wobbly. But really that in itself is the sensor. And I mentioned previously that it's a bed occupancy plus sensor in the sense that it does do bed occupancy, so in and out of bed, but it can also look at in-bed movements, heart rate, breath rate, weight, and all of those can be shown in the graph on the bottom left. So you can see multiple sort of exits, which are labeled bed exit, movements in bed, and then general load. And those are what help us send those text messages or alerts to that cell phone. We really just focused on bed occupancy, though the device does so much more than that. On the other side of it too, there is a web interface which can show sleep patterns or sleep disruptions across a specific timeline. So you can see on the right-hand side on the very bottom, there's some purple which show the nighttime in bed versus the yellow lines which showing get up times during this sort of nighttime or this designated sleep time, which can be looked at from one date to another date, allowing people to get sort of a general view of these patterns and sort of sleep disruptions. So that's essentially the sensor. It is plugged into a wall, placed under the foot of the bed. It's meant to go at the top of the bed, so towards the headboard, and it is strongest on the side that is a bed entry or bed exit, especially if there's a twin bed or a queen or king. It's better to be on the side that the person sleeps and enters and exits the bed. If it's on a sort of a single bed occupancy, it's not as important to have it that way, but it does make it a little bit more accurate putting it on the side that is bed entrance and bed exit. And I will come into that too a little bit more later. So the research site, just a little bit of a background on the research site that we used. It was a retirement community. This is not a long-term care site. This is mostly just for, there's no palliative care or anything like that. It's just a community for retirement with a design for residents with Alzheimer's and dementia. So it's got this quadrant design, and you can kind of see it there in that picture. There's 4 quadrants, and on the middle of each quadrant is an enclosed outside space, like a garden, place with chairs. And this way residents are able to go in and out without the risk of getting lost. And then a nice feature of this is that this quadrant has windows that lead into the inside of the building, and these are half wall windows. So for each quadrant, all the rooms are out on the outside of the hallway. On the inside, you'll see these nice giant windows which look into this outside sort of garden space, and it's quite lovely. There's around 20 residents in each quadrant, so around 80 residents for the total building. And during the night shift, there's 4 PSWs and one night nurse. So our learnings. So the TalkTech device, the bed sensor device, is placed under the bed, and then using an internet connection, we connect it to an app which sits on the cell phone that lives with the night nurse. And during the night, if there's activities such as getting out of bed and not returning, or getting out of bed and you want to know immediately especially if there's a high falls case, we can send those alerts, and those alerts are all done with the internet, which was our big point of learning. This care home, because it is not a medical care facility, it didn't actually include like a facility-wide internet. It did, however, have a residential internet, which was used to power a TV in the common space in each quadrant. So this was, an internet connection that was not necessarily meant to broadcast facility-wide. With these sensors, we do need to have an internet connection, and so we thought we could tap into this residential internet. However, those giant windows that look out into that garden space acted as barriers for this connection. So if on one end of the sort of quadrant, that's where the common space was, if I had a room on the opposite end, that network signal had to pass 2 windows, and that was just not possible for the internet connection. So what we did was thought, okay, we'll bring in Wi-Fi extenders, and there's these little things, you just plug them into an outlet. They extend the network connection, making it hopefully travel longer, and that would talk to our sensors. Unfortunately, they didn't work just because the signal in general was not powerful enough to sort of support that wide of a range. So then we thought we'll bring in some little portable portable routers, which worked really good, but they were definitely more beneficial for it. They could do one sensor. And since we didn't have all of our participants in one pod right beside each other, there was 14 spread across the whole facility. This meant that, we would either need to get single portable routers for every single participant, or some just had a weaker connection. And if it had a weaker connection, it was just less reliable in terms of sending out the appropriate notifications. So then we went to ZTE routers, which unfortunately are just an older technology that's not really supported anymore, which then brought us to LTE routers. So for those who don't know, an LTE router is just a regular Wi-Fi router, but it's powered by a SIM card, and we could put just data on this SIM card. And then I brought one of those into each quadrant that we had participants, broadcasted our own internet, and hung all of our TalkTech devices off of that network so that everything was visible to just the one router. And that solved our issue for the internet. Our other learning was in and around consent versus assent. So these devices, as I did mention, they are best when they're on the side of the bed that you enter and exit, which meant they were visible. Some participants would unplug and move or hide, or if they saw me doing the installation, because sometimes they were there or they'd walk in, they had questions and concerns. So we found it best to just do our best to hide them for those who, were consented or had their SDM consent. And in some cases, it just meant we pulled and we said, okay, not for this resident. So there was just some challenges in that aspect, but of course that's what we get. And it was definitely very eye-opening.
I'm just going to get to wrap it up, Laura. Sorry, we're at time now. So if you could wrap it up in the next.
Absolutely. This is the last slide. Quick user thoughts. The staff wished that more residents had the technology. They found that it made working hours more efficient, and the technology did support their daily work. So that's everything. Those are my references, and thank you.
Fantastic. Thank you so much for that excellent presentation. I'm going to encourage everybody to use the Q&A button at the bottom of your screen to enter any questions that you have for Laura. There is one question in here so far from Farah. Farah says, hi, I guess the sensor sense is based on weight. What is the threshold for error to avoid getting wrong alerts if something was put on the bed and not a person, for example?
That's an excellent question. And we actually did an extensive testing on this. And I wish I had all of the nitty-gritty details myself, but what I do remember is that the sensor was excellent at noting person versus not person. There was a bit of a, it depended on necessarily the bed size and the placement. So I did mention that, on a queen bed, if the sensor is placed on the, I'll say, far side, there was more room for error. If the sensor is placed on the close side, it's in and around, 50 pounds, where it would recognize a bed exit at that range. So it really does well with, low weights. We also did, I'll say, mock tests for if there was a pet on the bed. So we would have, I think we did a 90 weight person and a 30-pound dog, for instance. And if the person left the bed, but the dog stayed, the sensor was able to say, yeah, a person has left the bed. If the dog left the bed and the person stayed, the sensor also was able to say, yeah, the person is still in the bed, and not do an alert. So in terms of sort of error with multiple items or things on the bed, it's really quite powerful. You do a calibration for the sensor. So once you install it, you're supposed to sort of sit or have, the bed occupant sit on the bed for 5 seconds, and then it understands the weight that it's looking for. And then from there, it's best to do those alerts.
Okay, excellent. Thank you so much. We have a couple minutes for maybe 1 or 2 more questions. Olive asks, what was the main concern from the participants regarding the technology?
The main concern was that they were being spied on. So again, we're going into a facility with participants who suffer from dementia and Alzheimer's disease, and they felt that they were being spied on, or something was, I will say, wrong with them, and that's why they were getting this technology. So in some cases, we could hang back and maybe try again on a better day. Or in other cases, we honestly just had to say, it's not for this person. They are not willing to, accept the technology, and that's totally fine. It was just sort of part of the research and part of the nature of doing research with persons living with dementia.
Okay, great. There's actually quite a few great questions here. I'm going to ask one more just for the sake of time. We can come back to some of these perhaps, in the general Q&A afterwards, just to reassure people there'll be other opportunities. But the last question I'll ask you is, what about the detection of double occupancy in the bed?
Another great question, and something that we didn't get to. All of our participants were single occupancy. I know it's something that our research team has sort of played with to try and see, how it works. And again, it comes back to, I think, that calibration. So if you're calibrating, and you put yourself, and it's 150 pounds, the sensor knows that the plus or minus of 150 pounds is the person of interest, if you will. If you have 2 people who are in and around the same weight, we haven't necessarily traveled or looked at that, but it would be a very interesting case to study. Definitely a harder one, but I think very interesting nonetheless.
Okay, great. There is one comment that is a request that if you have any publications on this work, maybe you could put them in the chat box during this the remainder of this session. So thank you so much.
Dig anything up. Yes, thank you.
Wonderful. Okay, so now we're going to move on to our next presenter number 2, Amal Yadadin. Amal is a PhD candidate in rehabilitation sciences at the University de Montreal. She is also a certified occupational therapist since 2018. Her project focuses on the development of an innovative technological solution to help older adults with cognitive impairments to stay at home, as well as to identify new ways to deploy access to these technologies for this population. Amel aims to become an engaged scientist in the field of age tech, to lead innovative projects that catalyze social change and promote the social inclusion of older adults. So with that, I pass it on to Amel, and I again encourage people at any point during the presentation and of course afterwards to add your questions into the Q&A box. And we can see your slides, and so whenever you're ready.
Thank you, Jennifer. Hello, everyone. Thank you for the nice introduction. So my project is called Aging Well at Home, One Meal at a Time, and it presents the protocol of a multiple case study on the long-term use and perceived effectiveness of Cook My Safety for older adults. So first of all, in Quebec, more than 40% of home fires are due to a distraction, and 84% of these cases are caused by cooking appliances. We're talking about stove, microwave, toaster, but more often we talk about the stove. So we see that the kitchen is the room in the house where safety issues are the most present. So older adults, especially older adults with cognitive decline, are more likely to make critical errors in the kitchen. And unfortunately, to address these type of errors, overcompensation of difficulties is often the preferred solution by caregivers, by clinicians, or by managers of residents. However, overcompensation brings a risk of early institutionalization. And if we want to promote aging in place, engagement in daily activities, and to prevent safety risk, innovative services focused on technology show potential and can be a solution. And also older adults demonstrate an interest to use them if they are tailored to their specific needs. So why aging well at home, one meal at a time? First of all, cooking is a complex activity. It requires planning and organization skills, and it requires the ability to manage multitasking. Also, as we saw before, cooking is also a risky activity. The complexity of the activity combined to the cognitive difficulties related to aging leads to the risk of making critical errors, such as omitting to turn the stove before leaving the kitchen. And finally, cooking is a significant activity. It preserves the perceived self-efficacy, and it presents many health benefits for the human. So our solution is the cognitive orthosis for cooking named Cook. So in 2014, our team designed an assistive technology for cognition that is named Cook, that was initially designed for clients with traumatic brain injury. So its potential has been documented in several studies, as you can see. And we also conducted a qualitative study in 2020 to see if Cook can be useful for older adults. And the answer is yes. However, it needs to be adapted to their specific needs. So Cook is an assistive technology for cooking that is offered on a tablet, as you can see here. And it's connected to an intelligent environment that uses motion, temperature, electromagnetic contact sensors. And these sensors are placed in the person's apartment and allow to collect information on what the person is doing in the kitchen. So two systems interact in this application: a cognitive assistance system and a security safety system. The cognitive assistance system provides support to the person by giving cues, verbal assistance, and strategies, while the security safety system prevents critical errors by sending alerts to the person if a critical error is detected. And if the person doesn't answer, then the stove is turned automatically off. So here I'm putting together a timeline just to get a better idea of the large scope of this project, as well as the different steps that followed. So as you can see, prior to 2019, there has been a lot of work with the TBI population. Although this clientele has similarities with those of aging, and especially cognitive aging, there are several differences in the functional profile. For example, in the TBI population, we observe impulsivity, inaction, and difficulty to thinking before acting, while in older adults with cognitive loss, we observe slowness as well as difficulty in initiating an action without assistance. So based on this, we had an iterative process to test few versions of Cook, and we did some teamwork sessions to modify, adapt, co-design a more suitable version for our population. So for example, Cook, my culinary assistant that had the security and the cognitive assistance system, became Cook My Safety, which is really focused on safety and preventing risks. Of course, we did all this in a multidisciplinary team setting. So the currently we are conducting a deployment study as we deployed Cook among 7 older adults residing in a partner senior residence to test its extended use. So the deployment is about 4 to 5 months, which is really innovative for this type of technology. So our objectives are to identify the key usability issues that may interfere with the use of Cook My Safety by older adults in their homes for an extended period of time, to identify how to improve the technology and facilitate its large-scale deployment, and to identify the facilitators and barriers to the extended use of Cook My Safety by older adults and its future implementation factor as a solution for aging in place in Quebec. So here it's just to show that we have some methods dilemma, because even if we have a deployment prototype, we are still collecting data related to usability, satisfaction, learnability, etc. So it is as if we are between the lab prototype and the deployment prototype. And in fact, we brought the lab into the person's house while providing ongoing support to ensure acceptability. And it's quite the challenge. So here's a brief view of the methods. We deployed Cook in older adults' real environment in 7 houses for 4 to 5 months. We conducted interviews, questionnaire with the participant. We did the measurement in 3 stages. So before the deployment, during the deployment, and after that period to assess elements of usability and implementation, such as the number of hours Cook was used, the number of meals participant prepared, the satisfaction rates, etc. And we are aiming to do both qualitative and the statistical analysis to count and compare the quantitative data and to document the factors for the implementation and usability components. Up to now, the study is still in progress, but so far, high satisfaction rates and perceived effectiveness have been documented up to now. We identified the use of an electronic tablet as a challenge that remains, whether to manage updates of the tablet or to plug it when unloaded or to put back the Wi-Fi when it's been disconnected. Also, according to the participants, the installation of Cook for several months would allow to develop a better awareness of the safety-related risk, which was an unattended result to our deployment. Also, it is the first study in Quebec on the long-term use of an assistive technology for cognition innovative for our case, and also factors for adoption and appropriation of this type of technology are still So this study could provide the beginning of an overview to answer these important questions. If you have any questions, I'm here to answer.
Okay, thank you so much, Amel. Just a reminder to put your questions in the Q&A. And if you would like to upvote, there's a little thumbs up symbol in there. So please click on the thumbs up if you'd like the questions to go to the top of the list. I see some comments in the comment box that are very enthusiastic about this concept. Mark says that Cook My Safety sounds very practical, not just for older adults, and maybe fire departments would endorse this as they do smoke detectors. So I don't know if you wanted to reflect on that while others have an opportunity to type in their questions.
Yeah. Observation, we indeed tried to do partnership with fire departments, etc., but that will be more in the future. So as I said, we are in a dilemma. We are not yet in the deployment 100%. We're still testing and developing and but once we will get that prototype that is ready to be deployed at a large scale, for sure we're going to partner with fire organization and government based. Thank you.
Okay. Fantastic. Another question in the comment box, just a reminder to I'll monitor both, but if you put your questions in the Q&A, I'll see them a little bit faster. Brian asks, he states, first of all, thank you so much for the informative presentation. It's very interesting. The question is, from your perspective, do you think that this should be integrated with other smart home technologies or no? Interested to hear your thoughts.
And discipline team that focus on developing many technologies for other occupations in the house, including how we say it, sleep medication management, etc. So we are all working this together and create a new gamma of services to promote aging in place. So of course, the end goal will be to have all these applications in one touch screen that allow the person to live independently.
Okay, great. Maybe one more question. Susanna asks, she says, great presentation, thank you. May you discuss how you measured usability and satisfaction?
Yes, of course. Thank you very much, Brighton. We use both questionnaires. So we use the attractive and the system usability scale. So that is, we need to get more information of the questionnaire. So we also do
okay, I'm noticing some disruption in the feed. I don't know if that's on my end or on your end, but I think we caught the end of that. But with that, because of the time, I think we'll move on to the next presentation. So thank you so much again for an excellent presentation.
Thank you.
Okay, so now we are going to move on to the third presentation by Shrose and Penny, who will be invited to share their screen and give their 10-minute presentation after a quick introduction. So Dr. Shrose Khan is a scientist at KITE, the Toronto Rehabilitation Institute University Health Network. He is also cross-appointed as an assistant professor at the Institute of Biomedical Engineering, University of Toronto, and Dr. Khan's main research focus is the development of machine learning and deep learning algorithms within the realms of aging, rehabilitation, and intelligent assisted living. As a PI and co-PI, his research program has been funded through several Canadian, US, and other international and industrial grants, and he has published 68 academic papers in top international journals and conferences that have garnered more than 3,500 citations on Google Scholar. Penny Taylor, a patient partner with Chirose, is a 67-year-old woman who works in advertising and has an active lifestyle. Penny's right hip was replaced 12 years ago when she was hit by a car while cycling to work. After pool rehab post-surgery, she was active again within months. And in 2020, during COVID, she cycled 3,003 kilometers from March to December, averaging 20 kilometers daily. On the 24th of August in 2022, she fell at work and broke her left hip, which was replaced 2 days later. After 8 months of WSIB sanctioned physio and using an indoor bike, she is once again starting to cycle outdoors. So with that, we are very excited to hear Chirose and Penny. I will invite you to share your screen, which we can see perfectly well, and hand it over to you.
Thanks a lot, Jenny, and it's such a great honor to be presenting at the EPIC conference. I'm so delighted that we have Penny Taylor joining us today, despite the fact that she's working. So thank you so much. So I'm going to talk about this study that we are currently running in the community, and it's around assessing social isolation in older adults after their hip surgery and assessing their recovery. So just to give you a little bit of context, so more than 30,000 older adults experience hip fracture annually in Canada. And this actually puts patients at a high risk of social isolation, partly because of their mobility issues. And there's an immense cost around this fact, not only just the recovery, but also some other comorbidities arising from social isolation, leading to maybe, depression, weight gain, and other kind of problems. So, as I said, the functional decline is one of the prime reason, and reduced social activities can actually lead to more social isolation. So in this study, what we're trying to do is we're trying to establish correlation between the physical, physiological, and other social behaviors, kind of data that we're collecting from our patient partners, and then also trying to correlate it with the social isolation. So the general idea was that, because from the literature, we know that social isolation is connected to your mobility, whether you're going outside, whether you're meeting your friends and other kind of things. So we wanted to build a multimodal sensor system that can capture some of these aspects, including your sleep patterns, your physiological data, and we can somehow store this all of this data seamlessly in the cloud, without disturbing the daily activities and the daily life, or interfering with the daily life of our patient partners. So we built this system, what we call as Maison, and you don't have to worry about this architecture, but I just wanted to show you the types of sensors we used in the system. We use a smartwatch, smartphone, a motion sensor, and a sleep mat. The sleep mat goes under your mattress. The motion sensor, you can put it anywhere in your living room, and the watch, of course, you have to wear. The type of data that we can collect is very multimodal. So from smartphone, we can collect your motion data, also GPS information. Smartwatch can give us information around your motion, heart rate, step counts, and so on. Motion sensor can collect indoor motion, and sleep sensor can provide us information around various sleep metrics like sleep duration, sleep quality, and so on. So the app that we developed is very simple. You just need to have a button on the watch and on the smartphone. Just slide it, and it starts collecting the data. If you're not comfortable in collecting the data, the patient partner can actually swipe it, and it stops data collection. So they can control when they want the data to be collected or not. So far, we have collected data from 5 older adults, our patient partners, for 8 weeks each. And these are the patients who were discharged from the Toronto Rehab. And most of them are, actually all of them in our studies so far have been females in their 60s and 70s, living alone with without pets. We also realized as we went further into the study that a lot of these older adult patients are living with actually pets. So we made an REB amendment, and now we are more inclusive of other patients who are living with pets. The only requirement is that they need to have a Wi-Fi in their home so that the sensors can upload the data. We also do several bi-weekly assessments, clinical assessments, such as the social isolation scale, Oxford Keep Score, and there is a Tug Up and Go scale as well. And the overall idea is that we'll use the sensor data and the questionnaire to build the predictive modeling side of the things. This is just a quick snapshot of some of the data that we collected. This is not from any patient partner. This is from the research team. So one of us collected some data on ourselves. So this is just the acceleration. So you can see that this is a 24-hour time window, and we can actually see when a person is sleeping, when the person is moving, and things like that. We also collect GPS kind of information, so we can know different places that you're visiting, how much time you're spending, were you walking or driving, and things like that. So I would like to quickly touch upon the challenges. There are two types of challenges. One are the technical, and one are the other are the operational. In terms of technical, there are regular updates on the Android operating system on which this app is developed. The APIs are always changing, so we need to keep track of the software side of the things, the infrastructure. Otherwise, the app wouldn't work. In terms of operational issues, we learned from our patient partners there were concerns around the shorter battery life of smartwatches, and this is something beyond our control, but we are always looking for better watches. Some of the patient partners, told us that they sometimes forget to wear these watches, so we may, lose some data, although the compliance rate is phenomenal. And one actually older adult also complained about the weight of the watch. They thought it's a little bit heavy, while the others felt it was okay. So with this, I'm going to stop, and I'm going to let Penny share some of her experiences and let us know about the study. Thanks.
Thanks, Shiraz, and thanks again for allowing me to be part of this important conference. I'm a firm believer in the greater good, and as a senior, I'm sort of quickly discovering the all too often marginalized part of society that seniors fall into. So I'm very happy to help out with this. In terms of this study, it was a very easy process. Apart from the technical issues from time to time, there was pretty much little to no effort on my part, except for the days when I would walk out and forget to take the phone with me, which, I would, or else I would take my own phone thinking it was the study phone and the other way around. So there was a few days when that happened. In terms of suggestions about getting others to participate, I feel that targeting fracture physio clinics, waiting rooms and assisted living, common areas, in and outpatient rehab facilities and hospital waiting rooms, in the orthopedic areas with signage and, like a takeaway pull-off number. And, on the signage, it doesn't hurt to offer an incentive of something at the end of the study, gift card or whatever it is. I think, unfortunately, that didn't have a bearing on anything for me, but some people, need that sort of little push to participate in a study. In terms of the challenges, Shiraz went into a bunch of those. There was charging malfunction, notification malfunction, and difficulty dealing with the notifications. And I had to call a Faranac, our research assistant, and she was absolutely wonderful. The woman never had a bad day. She was always cheerful, always smiling, unlike me, who was the complete opposite. So she put up with a lot for me, I have to say. But so there was that. And then the phone, which we actually had to replace the phone at some point. It was hard to understand the setup of the phone. I'm an iPhone user, so Androids make no sense to me whatsoever. So, and also the charging cord had to be replaced due to malfunction as well. Again, leaving my place without the phone when I had to go all the way back to get the phone, because I know that it was an important part of the study. And what's the point of going out if you don't take the phone with you for GPS purposes. Also, one other challenge was the lack of charging of sufficient outlets in my place where I normally charge everything so I don't forget it, which meant that I would have to unplug the phone to charge the watch and the other way around. And so then I asked for another charging cord for another outlet, and that took care of that problem. But it was a bit of an issue in the beginning. So I'm, in terms of communication with Farnack, it was great because I'm tech savvy. Just because I'm a senior doesn't mean that I don't know how to be technologically on top of things. So we communicated by text, occasionally FaceTime and email, but mostly it was by text. And she was always, exceptionally quick to respond. Whenever I had a tech issue, it didn't matter what day or what time it was, she was on it. So kudos to her. In terms of what I liked about this study, first of all, being approached in the first place to me was just knowing that I felt supported and heard. And at this point, it was 3 weeks after my surgery, so I was feeling a little bit overwhelmed. Even though I had been through this 12 years ago, I'm also 12 years older now, and things, it was just the whole, having to live at Toronto Rehab for 3 weeks was interesting. And they worked us hard in physio, so I appreciated somebody coming up to me and asking me, is this something you'd be interested in doing? And like I said, I always want to help out whenever I can, so I appreciated that. And again, here I was doing the study in when winter was approaching. So there were a few days when there was like big blizzards outside, and Farnack would arrive at my place as cheerful as ever, never mind slogging through 5 feet of snow, she would do it. So I really appreciated that. And I also appreciated being tested for my mobility, my agility. Every couple of weeks when she came over, we would go through it. I would have to walk a certain distance and then, walk back, and she would monitor me, getting up off the chair and sitting down again. And so that was good because at that point I was in physio. And so having reinforcement in that regard was important for me. Now, one last thing, improvements for suggestions for improvements. Again, I think it's a little presumptive to think that iPhone users are going to be comfortable using Androids and the other way around. So I think it would be a really good idea if you could have a selection of both. So to give people the option so that they feel as comfortable as possible, because there were some days when I was completely baffled. I didn't know how to get past the home screen. I didn't know any of that. So it's a lot. I think with seniors that are not, maybe tech savvy, it would be even more overwhelming. So I think that would be a good thing. And also, I will say that not every woman likes a little watch with a mauve band on it. I never wear mauve in my life. You can tell I wear black. I like big things. I like, work in advertising, and I like to, make a statement. And a mauve band doesn't do it. So when they presented me with, and plus, it's part of my everyday style. I have to go to work wearing a mauve band, and I'd sooner like crawl away into a hole somewhere. So when I was presented with, this big sizable watch with a big leather band on it, I'm like, oh my God, this is perfect. So, I would like to suggest making things less gender-based in terms of colors available and sizing and all of that. Yeah, and so that's pretty much all I have to say. I was so happy to be part of this. I know this is an important study. It's important for, awareness in terms of seniors and their recovery, and hip surgery is no joke. It's no joke. And so, even when I was in my 50s, it was no joke, but it even more so now. So the fact that, there was this follow-up and that, graduate studies are investigating this, I think it's great. It's great. So there you go. That's my take on it.
That was excellent. Thank you so much for a great presentation. And thank you so much, Penny, for sharing those really powerful insights. I know that a lot of the practical considerations that you mentioned also really resonated with me as a researcher. So we really appreciate you sharing those so candidly. I think a takeaway from this session will be a mauve band just doesn't do it. And I think that that speaks literally and figuratively to a lot of considerations that are really important, are seriously really important. So I love that. Okay, so I would encourage people to use the Q&A and to upvote to ask your questions. We do have one vote from Brian already. Brian says, great talk. Could you speak about missing data? Specifically, does your model account for the instances when a participant decides to opt out of data collection? And can you speak a little more about that lost data and how it might be critical? For example, something that might be embarrassing for the participant, but useful or insightful for the researchers or physicians.
Thanks. Yeah, I mean, that's a very good question. So we did not have any instance about anyone opting out of the study. So that was a plus point. So everybody completed their 8 weeks. But there are instances where a person may have forgotten their watch or their smartphone, as we heard. But the good thing is, because this is a multimodal sensor system, so if, let's say, you're forgetting your smartphone, we may not get your GPS data, but we are still collecting your motion data from the smartwatch, right? So if you're not wearing your watch in the living area, we are still collecting data from your motion sensor. So there may be, like, we're still analyzing the data. We have 40 weeks of data. Just imagine how so many days. So Farhanak is currently, analyzing all of this data. So we have a few blank spaces, and we're still understanding, is it going to affect the overall model or not? But so far, I think Farhanak has extracted many features, and also it looks robust. But yes, you're right. In certain instances, our confidence will be low, and we'll have to see how we can include that data, or the lack of it, right? So that's the part. And the third part is about any embarrassing data. We do not collect any identifiable information, so we don't know what you're doing. It's just motion. So if you're moving around or not, so we don't know the actual activities. So I don't think that is a problem in this type of data. And patients have this flexibility to turn off their data collection if they think there's something personal going on. So yeah.
Okay, great. Thank you. Are there any other questions for Shiroz and Penny specifically?
And I really love this movement thing. I think we should make it as a slogan, movement does not work. I'm going to put it on Twitter. I just love this. Actually, we made this change because another patient partner before Penny, she thought the watch was a bit heavy and clunky. And I said, okay, yeah. So we changed it. And then here comes Penny. She's like, no, I don't want this. It was amazing. And it's a great learning curve for us. And I was having this conversation with Penny the other day, and one thing she said, and I think she also made it clear in her comments, like, we need to have more choices. It should not be just one color of band or one type of watch. And this is a great comment. We started with Android because of some a little bit easier to develop, but I think I totally understand this idea of expanding into iPhone types of technologies, right? So I think this conversation, and I think that is why we need a little bit more core design. I think we need to involve people like Penny and other patient partners to get their feedback. It's good to have more choices. It doesn't hurt, right? So great.
Yeah, really important points. We do have one more question from Farah. Do you use your historical data to predict future problems or identify needed modifications in the patient's rehabilitation procedure?
So we are not predicting as such. What we're trying to do is we're trying to do two things. First thing is trying to correlate this sensor data with social isolation. So we are currently in consultation with a biostatistician to help refine these features and build these statistical models, right? So the first thing is, because we collect a lot of data and we extract lots of features, I think at this point we have around 30 features related to your step count, motion, heart rate, this and that. So what we're trying to do is we're trying to correlate and try to identify the most important features that are a predictor of social isolation. Once that is done, the next part that Farhanak is going to work is to create these different user profiles. So as you can see, Penny is very active and she's a cyclist and things like that. But then we have other patient partners who are more homebound, who are not moving that much, right? So we have collected data from 5 people, and this study is continuously, like we're collecting data as we speak. So my hope is that when we have more patients, so the picture will be clear. Maybe we can group our patient partners into different clusters, and then we can look into their particular data and their path to recovery and how we can help, right? So we have Dr. Charlene Chu, who's a nursing professor, is also a co-investigator on this study. So she's gonna look into how we can help moving forward with this data set. Yeah.
Okay, fantastic. Okay, so so now we're at the point of our session where we're going to invite all the speakers back to the proverbial stage. And this is an opportunity for any questions to be asked of any of the presenters, or if you want to pose a general question that you think may be of relevance to all of the presenters or some of the presenters, then please pose any of those questions that might be a bit holistic in nature. But again, you can be very specific in asking questions of particular presenters. And just a reminder, that will be in the Q&A section, and you can upvote clicking on the thumbs up button. So we have about 25 minutes left in our session, so we could have a nice little conversation, discussion, dialogue here. So no question is trivial, no question is silly, so please feel free to ask any and all questions. We do have a couple that we didn't get to in the individual presentations. So while the other questions are percolating, I will ask some of these that we didn't get to. And so I think, so this is a question for Laura. How do staff members utilize this data, and is it shared with caregivers?
Another excellent question. So the staff members were more involved with just the alerts, just because of, I'll say, the nature of their workload right now. It's a lot for us to also go in and ask them to take some time out of their very busy schedules, look at data, and talk to us about how they feel about this data or what they think is helpful. We did give them a little bit of a background on some of the other pieces that could be implemented with this device, but just because of the nature around research, we really just focused on using it for bed occupancy and asked for their ask them to just sort of test it solely based on bed occupancy. In some cases, though, we did look further at some of the graph data just to see. I'll give an example. We did have a participant with Parkinson's, and we could actually see their tremors on the bed sensor just for the in-movement bed. It was just higher than what I will say somebody without Parkinson's was displaying. So something that it could be shared, it could be passed over to the care staff, but just for the research study at this time, we didn't do that.
Okay, thank you. A question for Amal. Can you speak to how close this product is being deployed?
Yes, so as I mentioned, we are between the laboratory prototype and the deployment prototype, but we are getting close to that deployment prototype and eventually the commercial prototype. We're working closely with a non-profit company that is based basically a cooperative that works on getting the products we are developing available in the market. So it's coming.
Okay, great. Thank you. I actually have a question for Penny. Penny, you touched on some great suggestions in terms of how to optimize, or how to sort of researchers can do better at the patient engagement or participant engagement piece of things. So I was wondering if you have any other kind of practical advice for researchers and how we can get patients or healthy older adults in the community enthusiastic about research and engaged in research, whether it be research that takes place in their home or research that takes place in a research lab, for example.
I mean, I think that's a good question, because I think, there are lots of research facilities that if I'm on a mailing list for a couple of them, and so whenever a study comes up, they contact me. So I've never yet seen a senior study on any of those research sites. So that might be another way to gain some reach. So I'd like to say social media. Unfortunately, a lot of seniors, and it's kind of taking over our lives. So it doesn't hurt. It doesn't hurt to somehow, there's ads that come up and they're very intrusive. They're very intrusive in emails. But I think that actually having actual physical copies, something tangible in all of those places I suggested, I think that would be, because it's, there's inevitably going to be people that are missed by somebody going around and recruiting. And I think that, people are sort of sitting around on an exercise bike and they've got, X number of their captive audience, so to speak. And, having that kind of, paperwork up there with, something very easy to pull off and take away, I think would be a great idea. And
Okay.
any rehab and, physio clinic. Yeah.
Great. Thank you so much. Okay, another question for Laura. Jim asks, is there any tracking and detection of quick weight loss as an indication of need for intervention?
Not that we did, but I don't see a reason why that couldn't be a use case for this technology, because it does take into consideration the weight in the bed. So, it knows that the bed weighs, I don't know, 30 pounds or, 300 pounds, depending on the type of bed. And then it'll get the additional load when a human, is in it. So, if that weight, 6 months ago is a certain number, and then, present day it's, 20 pounds less or something like that, there could be, and that's, cause for concern, that could be a use case for the technology. Again, with research, we do have to sort of narrow our scope to sort of one thing, and we just looked at the bed occupancy, but I don't see why that would be, why this couldn't be used for weight detection.
Great. And one more question for you. You're on the hot seat for a little longer. From Yasser, is there potential to detect or monitor sleep disorders with this type of sensor?
Definitely potential, not one that I know we're looking at, right now, but what we did do a lot of the times was look to see, who is, not sleeping very much, or who has higher sleep disturbances. In which case, that information could actually be passed to the physician, before and maybe even after medical intervention. So if a physician says, if the family comes to the physician and says, mom or dad or my loved one is really tired during the day, this seems new, perhaps they're not sleeping as much. And of course, that's really hard data to get from, staff. We could get the sleep sensor information. It could show very clearly that there's some sleep disruptions, in which case then a physician could say, okay, well, let me, maybe increase or add a dose of a medication that will help with sleep. And then, a couple weeks later, looking back at that sleep data and seeing if the medication actually did anything or if the dosage was wrong. Again, because it's still hard information to get from somebody just watching the resident at night. So very possible for, this kind of detection with the sensor.
Okay, great. And I'm looking in the Q&A and in the chat, and I'm not seeing any other questions. So I'm gonna end with one last question. I'm gonna ask this question of all of you, and we'll maybe do a 1-minute response to this question, starting with Amel. So what are your plans, dreams, and hopes for the future of age tech? So.
Oh, thank you. Thank you, Jennifer, for this very good question and very relevant, like for the heart. My dream for older adults is to be able for them to choose their own path, their own way to be independent, their own way to live their lives and have a meaningful life by doing meaningful activities and having the resources and the support needed to be able to do those activities. Because before being a researcher, I'm an occupational therapist, and I think that occupations are meaningful and are important for the health of the person, but also for in a spirituality level. So if someone is able to do the occupations that are meaningful for them, they are living a purposeful life, and that's my dream for older adults. So I hope that these age techs will come to an end like deployment and be able to help older adults for that.
Excellent, thank you. Sharoz?
Yeah, I think it's a very good question. And just to summarize, I would say our overall goal is to improve the quality of life of these old adults, living in the community. Be it like ours is focusing on is very specific hip fracture, but there are different types of patient partners who are living in the community. So quality of life, improving care are the key here. Now, I'm a technical person, so I also like to speak two things about this. So I also believe in people having control on their data. I want them to have full access to their data. So that is also very important from our design point of view, that we give this kind of empowerment to the patient partners so that they have full access to their data. They can see and they can decide what data should be collected by the researchers and for what purposes. And lastly, again, more my technological hat. I think we are at a place in time where we can actually build these systems. We have the relevant technologies, and we should be a little bit courageous and go out and let us fail a little while. It's okay to fail. Otherwise, I will never know that the movement doesn't work. Oh my God, so much stuck in my head. Right. So we need to go out, we need to talk, we need to have this communication, we need to build these systems and let it fail, let it learn from the mistakes so that we can move towards the actual path of helping people. And I don't want us to be deterred by, oh, the watch battery is not great. It's not great today, but tomorrow we'll have a better watch. Tomorrow we'll have a better phone. Tomorrow we'll have another better sensor, so it should not stop us from actually going out in the wild and try out these technologies. Yeah. So that's kind of my dream.
Excellent. Laura?
Excellent. I echo both of those comments as well. And I'll just add in, as I do have an engineering background, one of my, hopes and dreams for sort of the age tech space, but also the research space, is that we also focus on solving problems that actually support the issues people are experiencing. There's a common saying that engineers really like to solve problems that don't even exist. So I, hope to kind of continue working in a space where we're communicating with the users, on a front end basis, and sort of getting sort of that feedback, that continuous feedback from actual users of the, products, systems, and devices that we're working with, to sort of see how they could be used in that age tech space, and continue making it so that all these kind of applications and technologies are available for everybody worldwide.
Thank you. And the last word to answer this question, Penny.
Oh my, I've got the last word. I pride myself in having the last word, actually. Funny you should say that. Anyway, I would just like to see, first of all, I'm thrilled that seniors are being taken into account for age tech. I would love to see whatever the outcome of all of this studying and research, that it gets applied. And please continue to allow seniors to feel included and wanting to better their lives and make them feel that they have value and that they're being heard. So thank you for all of this. Appreciate it.
Excellent. Thank you so much. Okay. I just see one last question, which is actually for Age Well. So you guys are off the hook for this one, but it says, do you facilitate or coordinate the work of different researchers or inventors when they are interrelated like today for better and comprehensive solutions? And the answer is yes, Farah, that is exactly what we do. So you very much in a nutshell have summarized that we really try to, put people together who are researchers and innovators and industry partners, of course, patient partners and end users, older adults and care partners, and trainees, or the very important kind of next generation of innovators. And so there's lots of different mechanisms and different ways that we do that. So feel free to reach out to us offline and check out the website. Of course, attend the rest of the EPIC conference to hear more. And we look forward to talking to everybody about the ways that Age Well can broker those relationships and collaborations. And I want to point out, I'm just looking for any last questions. I would encourage the presenters today to go back to the comments section and have a read. There's some really wonderful sentiments that are being shared and some great insights into the comments. I'd like to thank our audience or our attendees today for being such a excellent interactive group. Of course, thank you so much again to the presenters for a fantastic session. We hope that everybody is going to join us for the rest of the week, next week, and the rest of the conference. And we look forward to seeing you at all future events. So thank you so much. This session is officially adjourned.